We're trying to move away from people hearing the term palliative care and equating that with death. It's about living.
I felt much more protected after we had our session with the palliative care team.
We wanted to do a better job at early intervention with palliative care in an outpatient setting.
So we really started from the ground up. We used what we had here in our cancer center because we didn't have any outside resources.
We pulled together a work group really to sit down and say, what do we have already in-house? What could we do better, and how can we shift sort of our focus from being reactive in the cancer center to proactive where palliative care is concerned? We had to start somewhere. We had to use the resources we had, which is really three major things that we're doing, and they are a weekly case conference that's multidisciplinary, that involves all departments within the cancer center. We have early identification of patients who we can conference about and talk about symptom management, talk about, are we at the point where it's appropriate to pull this patient in for a goals of care discussion? And that's the other piece that we try to do, is early onset of goals of care.
Instead of just talking about treatment, we look at people from a holistic aspect, a whole round aspect, and say, what is it that you really want? We actually listen and the patient talks. And the fact that somebody's listening to them, and then the fact that they're driving the ship, makes a big difference.
There is an inevitability about Frank's disease. Glioblastoma is not curable. I honestly, from my own personal point of view, don't know how people survive with day to day without having that network. It's like a warm blanket almost.
Sometimes patients really need someone to say, it's okay, you don't have to continue with the next round of chemotherapy. We can talk about, your value. You might want to be at home sitting on the porch with your family as opposed to sitting in a chemotherapy infusion room and getting another round of treatment.
It's a lot of what we do in our goals of care meeting is break things down very simply and very basic in terms of not overall, do you want to quit treatment? That's a very broad statement that sounds negative. I'm quitting something, I'm not going to get any treatment, to really individually talking about each treatment decision. And then the third thing that we've been working very diligently on is identifying professionals that are part of the treatment areas, part of the navigation team and the supportive care services team, who are willing to come together twice a month to develop their palliative care skills and be leaders within the cancer center as palliative care specialists.
I would like to think this should be the norm throughout all cancer programs, throughout all healthcare, but I think what was really innovative is how we went about doing it. We really grew this from the inside out. It really is a testament to how important this was to all of us.
And we know from literature and from the research that we did early on that early intervention with palliative care leads to better quality of life. It also leads to, in some cases, longer life. And it leads to a smoother process to care for patients and to make sure that we are able to really nurture people where they are.